All right, good afternoon, everyone. We're going to get started. I assume that there's still people who are going to finish up rounds. I know the hospital is incredibly busy, so we expect a few more people to join, but we're going to get started with pediatric grand rounds. Welcome to everyone, and in particular to our guest speaker, Dr. Michelle Guy. Michelle Guy is a professor of medicine at the University of California, San Francisco, here, UCSF. As a clinician educator, she leads faculty development programs to create an inclusive learning environment for students and trainees across all educational settings. She's the director for equity and anti-racism continuing education for the UCSF Differences Matter multi-year initiative that I think you all know of. I think many people in our department have taken the course through the Differences Matter initiative, and that course is all started by Dr. Guy. The one-day training she leads for faculty and staff has trained nearly 3,500 participants. Amongst those 3,500, many of our people in the department. She lectures nationally on mentoring across differences, implicit bias, and becoming a more inclusive and equitable educator and leader. From a clinical perspective, Dr. Guy is an internist, primary care clinician, and obesity medicine specialist, caring for patients with complex chronic medical conditions. She has been recognized for her outstanding clinical care with multiple awards, including induction into the Gold-Headed Cane Society. She graduated from the University of Michigan with a BA degree in comparative literature and earned her medical degree at the University of Missouri, Columbia, completed the residency in primary care at Cambridge Health Alliance, Harvard Medical School, and then after a chief residency came to UCSF to be on faculty here. And the topic that she's going to talk to us about today is at the intersection of her work as a clinician and an educator. As a clinician, she serves a diverse patient population, including women of color and patients with obesity, and often hear patients' experience of feeling discounted by the medical system. As an educator, she teaches faculty on learners on anti-bias and anti-racism to create an inclusive learning environment so we can all provide more equitable care to our patients. And when Dr. Guy and I were talking about the topic for today, I just realized how much we can learn about how we document things in the medical record in a way that really makes us cognizant of our own biases and does justice to our efforts to create a more equitable environment. Dr. Guy.
Thank you, Sandrine. I really appreciate that introduction. I think about that talk we had when you first invited me. It was probably more than 6 months ago. And at that time, I was thinking about note writing and how much we communicate right through our medical notes, especially as an interprofessional team. And what does that communication do to promote or discount health disparities? And so that's what I really want to explore today. So thank you for having me. So with that, I'd really like to start with a land acknowledgement. And I want to honor the native lands of which we are on and acknowledge the Ramaytush Ohlone people who are traditional custodians of this land. And I appreciate Dr. Ant Montgomery, who helped create this statement that we use in our own division and department and many other departments at UCSF. So we pay our respects to the Ramaytush Ohlone elders, past and present and future. They call this place the land UCSF sits upon their home. We're proud to continue their tradition of coming together and growing as a community. Thank you to the Ramaytush Ohlone community for their stewardship and support. We look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And also, I'm mindful of 2 recent deaths this week, that of Kenneth Nadife in our own, my Department of Medicine trainee, as well as the passing overnight of Bell Hooks, author and scholar, who wrote At the Intersection of Gender, Race, and Class to Empower Black Women and Working Women. So I'm thinking of them today. I have no financial disclosures, but my more personal disclosures are that I am an adult medicine physician. As you heard in my bio, I'm also a specialist in obesity medicine. But I really, we'll try to open up and focus on some at least adolescent examples here. And I'm mindful of many of the things that I might talk about as pediatricians you may not encounter in your own patients, but also, think more broadly about not just the patients, but their family and caregivers, and how sometimes our communications with them can also impact the language or the tone that we use in our medical notes. I'm also mindful of my own identities, and as a cisgendered woman of Afro-Caribbean descent, with multiple other intersecting identities, I may have times where I may be more or less cognizant of others around me. And especially as we think about others, this is one of the things I want to emphasize today. As part of the objectives, we're going to analyze language in the medical record to categorize them as anti-biased or stigmatizing. We're going to recognize how implicit bias in stigmatizing language may perpetuate healthcare disparities, and then consider ways that we can mitigate that and give each other feedback and so forth. This is a photo I took of a owl butterfly. And I think about butterflies as a way of just kind of bringing us back to nature, and thinking about how much of the patterns of butterflies and what they have is really meant to communicate, right? So either to communicate to those that are like them, to bring them closer, or those that are predators, right, to ward them away. So those are actually two butterflies with their distinctive circle. And when they come together as like-minded, right, as a pair within the in-group, then they're able to ward off and have the appearance of the pygmy owls to scare off predators. And so thinking about in and out groups is very much instinctual, it's very much in nature, and it's part of the biology in which we're wired. And so our brains have evolved, right, from that instinct, but sometimes, especially when we're tired and hungry and under stress, that instinct also impulsively takes place. And so that's some of the things that we'll think about and focus on, and then how do we overcome that? So I did promise open notes. And so I just wanted to start off by saying that, we could spend hours talking about open notes. And I really want to just focus today, though, specifically on how notes might perpetuate bias through stigmatizing language. And so the hope is that in this era of open notes, it's just one more impetus for us to think about the way we communicate and work with patients. And so at the beginning of April 5th, 2021, that 21st Century Cures Act now requires everyone nationally to provide patients with access without charge to all health information in their medical record without delay, as the law states. And with that, certainly UCSF Health, where I practice, when that came around, we had many talks that came to us, and there was a lot of trepidation and anxiety, I think, among the providers, and thinking about what that would bring. But actually, many institutions, including globally especially, have been using open notes for a long time. The VA is another example of that. And what they found is that really patients report a lot of clinical benefits to reading their notes. Patients who read their notes find that they have improved understanding of their health and medical conditions. They recall their care plan more accurately. They're better prepared for visits. They're also feeling more in control of their care. They take better care of themselves. They take their medications as prescribed and more frequently, and have more successful conversations and stronger relationships with their doctors. So all those things we think should improve and make health inequities better, right? And so as we look at the literature, the hope is that, in 10 years, we're gonna see some of that needle move and some changes within health equity. The VA, for instance, has been using open notes for a number of years. They did a study looking at open notes from 2011 to 2015, looking at almost 900,000 records. And with that, they saw that only about 16% of patients actually, even though they had the notes available to them, read the clinical notes. And although many had access, and they all had access, when they compared the users to the non-users, the users were usually younger, were more likely to be white, were less likely to be financially vulnerable, and oftentimes they would identify as a member of a majority ethnic group or race. And so with this, I plan to focus more on the language we use so that then we can move forward to think about then how we communicate with patients. This is one such study, do words matter? And then what do patients find judgmental or offensive in outpatient notes? And actually when this first got put out that I was giving this talk, our own Dr. Alicia Fernandez, thank you, reached out to me, and her sister, Leonora, does a lot of this work. So this is actually a publication that she put out, and looking at open notes and looking at the adult ambulatory patient portal accounts in open notes of over 7 years. They asked patients 2 questions. Have they ever felt judged after reading a note? And have they ever felt offended after reading a note? And of the 22,000 plus respondents, 1 in 10, or about 11%, felt judged, offended, or both. And patients who reported poor health, unemployment, inability to work were more likely to feel judged or offended. And 1 in 10 respondents who felt judged or offended by something they read in the note found that the perceptions that offended them or they found judgment around were errors that were created or surprises, often labeling language or evidence of disrespect. And so we'll focus a little bit more on that as we go forward. This is another study put out very recently looking at the era of COVID-19 and the rising concern for racial justice by the Commonwealth Fund. And they've asked people in the last year, actually mostly Black and white Latinx, accessing the medical care system. In the last year, what experiences have you had around racial discrimination in the healthcare setting? So when you go to see a doctor. And 1/3 of Black and Latinx households experience discrimination, racial discrimination within the healthcare system in the last year. And when they looked at what parts of the healthcare system, it's pretty ubiquitous. It's all parts, inpatient and outpatient, ambulatory, including pharmacies, urgent cares, et cetera. And when they asked them to really define and talk about what types of discrimination they experienced, about 20%, almost 20% for Blacks and a little over 10% for Latinx noticed overt discrimination at the doctor or clinic. Sometimes it was more commonly that they weren't offered the best available treatment, as well as denied timely access to services or not offered referrals to specialists. So you might have seen over the summer the JAMA issue that focused on health inequities. And one of the articles I want to point out here is that of David Satcher, his opinion piece on race and patient-physician relationship. And he says that although nearly 50 years have passed since the article entitled that he wrote, "Does Race Interfere with the Doctor-Patient Relationship?" published in JAMA in 1973, the question is as relevant today as it was then. Yet medicine still struggles with how to advance health equity, quash racist beliefs and biases in the profession, and reform racist systems and structures that have created, perpetuated, and exacerbated health inequities. If ever there were a time to re-examine patient-physician relationship thoughtfully and critically, it is today. And I give you that also because of this era of open notes. I think the time is now for us, and it's even more of a push for us to do this. Back 2003, the IOM report, now Institute on Medicine, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare was published. And with that, they looked at the levers, right, for healthcare disparities. And within that, a proportion of it is discrimination, bias, stereotyping, and uncertainty. And that's really one that we haven't really begun to solve enough to really see a difference in a lot of the health disparities that we see. So thinking about physician and implicit bias, here Chapman back in 2013 looked at a lot of different studies that have been done. So this is 10 years after the IOM report. And then looking in that period of time, the new literature that had come out. And among the almost 20 articles or so that they cited, cultural stereotypes may not be consciously endorsed, but their mere existence influences how information about an individual is processed, leads to unintended biases in decision-making. They looked at physicians not being immune to, of course, implicit bias, as we well know. And they looked at uncertainty and time pressure surroundings as diagnostic processes may promote reliance on stereotypes for efficient decision-making. And then physician training emphasizes group level information like population risk factors and may expose trainees to minorities in unfavorable circumstances of illness and addiction, thus reinforcing the stereotypes. And then physicians' vast knowledge of scientific data may create a strong belief in their personal objectivity, promoting biased decision-making. So we know that through works of others, when someone purports to not have a bias, that's often when they're going to be more biased. And in that same paper, you can see there the almost 20 articles. You can't read it very well, but sorry. But you can see the idea of the breadth that they looked at. And Lisa Cooper and colleagues found that physicians' implicit pro-white bias on the IAT correlated with Black patients' perceptions of poor communication and lower quality of care. And Penner found that all Black patients were less satisfied with physicians who had low explicit but high implicit race bias. And so even though explicitly, outwardly, they weren't saying things that were racist, when they had a high implicit, so such as on the IAT, they rated them as less warm, friendly, and team-oriented compared to physicians with equal degrees of implicit and explicit bias. So I thought that was interesting. So why do we stereotype? Why do we have bias? Let me give you a little just cognitive exercise here. So what do you see? Do you see a duck? Do you see two ducks? Do you see two rabbits? Do you see a duck and a rabbit? You probably within the same image don't see a duck and a rabbit at the same time, right? And so when we look at it, if I said then, what if you look for a duck eating a rabbit, right? Our brains are incredibly uncomfortable with ambiguity, uncertainty, and change. And so our brains have evolved to operate with this super fast, energy efficient prediction machines, right? And with the sole purpose of keeping us alive and safe. And they do this by relying on a lot of shortcuts and patterns. And so when we see a pattern, we often then will put it on the other image. So you probably saw either two ducks or two rabbits. And then it took you a second to kind of switch over and see the other animal. But our brains aren't going to let us see both the duck and the rabbit in the same drawing, right? So you can see a duck maybe eating a rabbit or vice versa, but you're not going to see the duck and the rabbit in the same image. So what is that neuropsychology of bias? Recently read The End of Bias by Jessica Nordell. It's a very good book. And she had a lot of really great examples. And one of the things she wrote in there in the chapter 2 inside the bias brain, holding and confirming stereotypes make people feel good. Right? Holding them provides an illusion of certainty in uncertain situations. And finding evidence that they are right is also very confirming. It's very affirming when we put out a stereotype and it gets confirmed. Finding evidence that you're right is affirming. Having one stereotype confirmed can also be physiologically pleasing. Prediction, pleasure from seeing a pattern that's expected. The outcome can often be uncertain. So correctly predicting an uncertain outcome activates the reward centers in our brain. And stereotyping is an act of predicting an uncertain outcome. So if we have a friend, let's say, who's always late, and we're there and they're like, well, so-and-so is probably going to be late. And lo and behold, they show up an hour late. You are likely to, with some glee or gratification, oddly, feel like, aha, I was right. Right. So you have a stereotype, and then when that prediction is come true, there's some amount of satisfaction with that. So our brains feel rewarded when predicted reality and actual reality match. And our brains both love to be right, but don't like to be wrong. So that uncertainty when you're looking, as a duck, is it a rabbit, can be really difficult, right? And so we can feel threatened when our stereotype predictions don't come true. And so we can have stereotypes around all different types of social identities, right? So many are listed there from that diversity toolkit from the NIH. And any time, again, we'll come back to this in and out group, right? So if you hold a social identity and someone is not within the in-group of that social identity for you, then the stereotypes that you predict for them might more likely not become true or not be confirmed. And then that heightens that sense of sort of fear or that amygdala being activated. And so when we think about in and out groups, it's the amygdala activation that will produce then that fear, flight, fright, or fight response. And it takes our lateral prefrontal cortex, where empathy and mentalizing happens, to kind of overcome that instinctive system one thinking, as we call it. So the use of the amygdala and other functions and processes are that fast, automatic, reflexive. The system two, the lateral prefrontal cortex, is more involved with higher cognitive processes, working memory, goals, planning, self-control, etc. And so if you think about all the different types of social identities and intersections of social identities, you can think about either having aphilia or dislike or repulsion towards a particular group, right? And this axis is warmth and cooperation. And so lower amounts of warmth here, and that gets higher. And then you can think also, if you have instinctive thoughts of like that person is of high status or competent versus less status or less competent. And so down here we have a low amount of status and competence and a low amount of warmth or cooperation. Whereas up here in the top right corner, you would have a high amount of warmth and cooperation for that particular stereotyped group, and the most amount of status or competence attributed to that group. And so if you think about any particular one of these descriptions that we might see in a medical record, think about then for you as an individual, then where would I put myself or the person that I'm encountering compared to my own experiences and beliefs on these continuums and on these axes. So you can imagine if you're someone who comes from, let's say, a lower economic status, and so that's your people, right? Then when you encounter, say, a patient who's very rich, then you might have maybe not a lot of warmth for them, but the social norms and so forth might make you think that they have a higher status, but maybe you might find them more threatening. And so they might be down here, even though society at large might put them up here. So your own individual experiences certainly project your way that you categorize someone. And again, our brains automatically do that categorization. I developed with some help of others this thought about like cycle of oppression to then turn it around and think about our cycle of anti-oppression. And so I'm going to go through this a little bit. So thinking about the individual, as individuals, we stereotype, and through self-awareness, we can overcome some of those stereotypes. But that's very much intertwined with then our interpersonal relationships. So through stereotypes, we might perpetuate microaggressions, or with more awareness and interaction with other groups that are different from ours, we get better at mitigating microaggressions and being an ally. And then all of us as individuals then make up this institution, but the institution itself will have its own norms and practices that then either could perpetuate or break down a stereotype. right? So I'll give you an example of women are bad at math is some example we think about. And so if I myself think that, then I might not say, I might invoke that when I'm going to take a test. And so if I'm going to take a math test and I think women are bad at math through stereotype threat, then I might do less well on the test. Interpersonally, maybe if I hold that stereotype, then when my sister goes to think about her, let's say, college career, and if she's going to major in math or something else, having me put that stereotype onto her and saying, oh, women are not good at math, then she might choose an alternate career. And then she gets to college, and within the institution, she sees that same stereotype played out because there are a few people who look like her, women or women of color, particularly that aren't math professors. And so the institution is then perpetuating that stereotype. And then that, let's say she graduates and she goes into maybe publication or some kind of media or making movies, and then societal projections of women aren't that good at math then get continually projected. And so as a society, then we perpetuate those norms and values, which then affect the individual. And so this is all a cycle that can go back and forth and interact. But if you put a new lens on it, so especially a historical lens, then you can think about overcoming the stereotypes. So if, say the movie Hidden Figures comes out and you see that there were women back in the 50s who were working with NASA and were really great at math and science and helped launch the space shuttle and sent a man to the moon, then you would more likely, not continue or perpetuate that stereotype. And so through a change in societal norms, then the individual changes and that interpersonal interaction grows. And then the institution also might have different inclusive policies or practices. And so I think that this view through a historical lens is really important. I hope that you've gotten to hear from Dr. Kamara Jones, our UCSF presidential chair, and she talks about the 7 roots of racism denial. And one of them is having an ahistorical stance. And so I want to briefly take you through healthcare disparities and a brief kind of historical look at it. James Baldwin said, history, as nearly no one seems to know, is not merely something to be read. The great force of history comes from the fact that we carry it within us, are unconsciously controlled by it in many ways. And history is literally present in all that we do. So one such history in medical education comes from Abner Flexner. In 1910, he was commissioned by the Carnegie Foundation to look at all the medical institutions, medical schools in the US and Canada. At the time, there were 155, and he visited all of them. And there were some good things that came out of it. There were higher admission standards for students, adherence to scientific method and research, and then oversight by state licensure boards. But some of the negative consequences impacted both African Americans and women. And 15 years after his report came out in 1915, of the 155 original schools, 89 of them closed. And of those 89 that closed, it was 5 of the 7 schools that were devoted to educating Black physicians. In August of 2020, in JAMA was published an article where they looked back to see, had those 5 schools stayed open, and there were 7 total Black schools educating Black physicians, we would today in the physician workforce have 35,000 more Black physicians than we do today. Women were also impacted by the Flexner report. In 1900, women accounted for 6% of practicing physicians nationwide. And in 1909, just 9 years later, they were accepted to 91 of the 155 schools, including 3 schools that were exclusively dedicated to women. And by 1940, that 6% of the physician population went down to 4%. women. And so over time, it took till the 1960s, another 20 years for that to become parity, more 50-50 enrollment. But it wasn't till that's when they started to catch up. But that lag still affects us because women, as we know, have less compensation, fewer leadership positions, and fewer research publications. And so we could potentially say that that's from that historical background or perspective. I hope that you've gotten to take a look at Hannah Jones's great work, the 1619 Project. And from that, Linda Villarosa wrote about John Brown. John Brown was an enslaved man in Georgia on a plantation in the 1820s to 30s. And he was led by his enslaver to Dr. Thomas Hamilton, who was obsessed with proving that the psychological differences between Black and white people existed. Hamilton used John Brown, to try to determine how deep Black skin went, believing that it was thicker than white skin. And eventually, John Brown was able to escape to England, and he wrote an autobiography in 1855, Slave Life in Georgia, a narrative of the life, sufferings, and escape of John Brown, a fugitive slave down in England. That's ancient history, no. Today, in 2016, we looked at attitudes of medical students and trainees about pain. And 40% first and second year medical students supported the belief that Black people's skin is thicker than white people's. So that gets perpetuated over time. That's part of that social norms and constructs that get taught and then passed on. And then we might perpetuate it by just prescribing less pain medication, et cetera. And so that's just one example of how history is still with us today. I'm going to give you a few more just based on some of the other health disparities and looking at kind of neighborhoods and environments, thinking about economics and education as well, and food security. So this is a map of San Francisco and Oakland, Alameda, and it's a redlining map. So redlining happened in the 1930s by the Homeowners Loan Corporation. There were 238 US cities that were given grades and color-coded such as this. And so green was considered the best and given a grade A. B, color-coded in blue, was still desirable. Those neighborhoods, the color-coded in yellow, were deemed as definitely declining, and those marked in red were deemed hazardous, and thus the term redlining. And so not only did individuals living in these neighborhoods were not able to secure home loans, but there was just generalized disinvestment in those neighborhoods. And so over time, that certainly had its impact in several ways. So this is, this is a map of San Francisco. Again, this is Google Maps of just pharmacies in San Francisco. And I'll just take you back here. So the red areas, Bayview, Hunters Point, you'll see here. And so if you look to this map of pharmacies, there's no pharmacies. This was just from a month ago. Google Maps of pharmacies in that area, Bayview. If we look at food deserts, this is really a great website, UCSF Health Atlas. And this is one of the stories they put together, but you can also do your own searches based on socioeconomic indices and demographics. And so this is looking at, again, San Francisco, Oakland, Alameda, and households with children under 18, and then poverty among all individuals. And especially in one section here, if you look, there's only the food co here in the Bayview's Hunters Point. And in this particular section of Bayview Hunters Point, it has 55% children under 18 and a 36% poverty rate. And so Bayview families have access to only one full service grocery store. And in that census tract, it's considered a food desert. People living in urban food deserts have to travel over half a mile to access healthy foods. And 1 in 5 Bayview households have no access to a car. And so the Bayview's hilly terrain and unreliable public transportation make it harder for residents to access grocery stores today. And so that's just one example of many of historically how redlining still affects us today. Here's another one published by one of our own medical students, JMP students who graduated last year, one of my students. And here we're looking again at the redlining maps. And then this is looking at those who with asthma who presented to emergency rooms with asthma-related complications. And again, it tracks with those same formerly redlined areas. And part to say about the infrastructure is that those areas, when they also looked at air pollution, were over 2.5 times more likely to have diesel particles and more matter in just those communities and the air there. And so another healthcare disparity that's a direct link back to redlining. And so when those communities were disinvested, then again, people weren't able to secure loans. And what that's happened over time is create this enormous wealth gap. And so whites, as a community, a family might have up to, on average, $171,000 of accumulated wealth over time. Blacks have $17,000 and Hispanics $21,000. Median household accumulated wealth, and this is up 2016. And then you might think, well, maybe that's to do with education, but it's actually the opposite. And so those with higher education have even more of a gap than those with less than high school education. Well, let's get back to words. How does bias in words get manifested or perpetuated? So here is newspaper articles from Katrina in 2005, the devastation that happened to all those in New Orleans. And in some articles where people represented as Black were depicted, often the word looting was used for those just trying to get means and survive. And then words like finding bread and soda were used when talking about photos that depicted people who appeared as white. And so words do matter. And so those biases that we have within society get perpetuated by the words we use. So let's do a case. So here's a case. I took this from, well, I've adopted it from Dr. Rainey at Stanford, and she put out the great educational tool at MedEd Portal, if you want to find it, to teach on anti-bias workshop on healthcare professionals reducing stigmatizing language. So in this case, try to count how many words or phrases might be deemed as stigmatizing. So as I go along, try to count and come up with a number. So CS is a 17-year-old obese diabetic girl with a history of childhood trauma, insulin-dependent diabetes with neuropathy, anxiety, borderline personality, pseudo-seizures, and slow transit constipation, with frequent admissions for pain and poorly controlled diabetes and DKA. She's brought in by her mother, who is wheelchair bound. Her mother is seen as demanding and medically unsavvy, and the patient's father committed suicide. She's a bounce back to the inpatient pediatric service after a recent discharge, and she no-showed to post-hospitalization follow-up for an outpatient appointment. Of note, the patient has been a frequent flyer to this ED and multiple institutions for opiate seeking and poorly controlled sugars. She says her pain varies between a 10 out of 10 and a 0 out of 10, depending on the moment, and she's exceedingly unreliable historian. Her descriptions of events and complaints of pain shift frequently with retelling, and she is very hard to redirect. She's also attention seeking, and she contorts and moans in pain when she's in earshot of providers. And when she thinks she's alone, does not appear to be in any distress, sitting up in bed and talking loudly on the phone. There's no clear cause to be found to date for her pain, despite several comprehensive workups. All labs and imaging have been completely normal. Urine toxicology is clean. Patient's mother and patient refuse to accept that no other diagnostic interventions are recommended and are demanding to see the most senior doctor in the hospital. They also demand to be cared for by more competent physicians, RNs, and consultants. All right, so come up with a number, think about your number, and we'll come back to that. So this is a one study paper that's really looked at the relationship between stigmatizing language in the medical record, and then does that have an impact on disparate care? And so Godu and team looked at stigmatizing language in the medical record and described patients either as, well, it was the same patient, but with stigmatizing language or without. And they gave then this record, just like the case that I read you, but a little different, to 413 physicians in training and medical students, and asked them, they were in the emergency room setting in an urban academic medical center, and rated then their attitudes. This patient was a patient with sickle cell, and so there's a validated tool for positive attitudes towards sickle cell patients. And so they used this validated tool to ask them if they had more kindness towards that patient or not, versus if they read the stigmatized language in the record or the unstigmatized. And then for the trainees themselves, they asked them then, for the patient's pain, what would you prescribe? And so what they found is that, here's the vignettes that they used, but the more positive, those who read the neutral language had more positive attitudes toward the patient. And then those that read the stigmatized language had more negative attitudes toward the patient, again, using that validated PASS score tool for patients with sickle cell. Then when they asked the trainees, how aggressive would you be in pain management based on which treatment they chose, those who read the neutral language had statistically a higher, more aggressive pain management than those who read the stigmatized language. So the stigmatizing language can have an effect on patient care. This is a few studies that have been done to look at this. So here's another study by Park, who conducted a qualitative study analyzing randomly selected encounter notes in the electronic record and in ambulatory medicine. And of the total of 138 clinicians with over 507 patient encounters, 69% were identified as women, and then 80% identified as Black or African American, 15% were white. And so they looked for patients who were more minoritized in this study. And 600 encounter notes included, they looked at both they came up with 5 major themes representing negative language. But more interestingly, I think too, is like, let's think about the positive things we can add to a record. And so they also came up with these positive language that you can also see. And so I think this is important to just think about moving forward, not just the stigmatizing language, but what are like positive and more health promoting things that we can write. So the power of language and chronic pain is important. I mean, I started with this history of John Brown and how it still gets perpetuated today. And so language often then shows up for women, especially medically unexplained, describing them being more gender biased. And so in this meta-analysis, they looked at the gender bias, and often men were described as more brave, whereas women were described as more emotional. And in terms of describing pain, that absence again of organic pathology for women and not acknowledging true suffering versus more aggressive treatment for men. And then if we look at substance use disorder, which often also is a very stigmatized disease, looking at Kelly's work, does it matter how we refer to individuals? This study looked at the stigmatizing language. And when they used the word substance abuser versus substance use disorder, and they showed it to clinicians, the substance abuser clinical vignettes, those patients were seen personally culpable for their disease and had and used more punitive or judging against them terms when asked. And then Dr. Fernandez again looked at, again, those who felt judged and offended, and took a look at the different types of frameworks and themes that came up with those. And she gives some nice thoughts about examples or suggestions, which I'll outline here a little bit more. So mindful language, thinking about, I use this word intently to convey that we're moving out of that automatic system one thinking, the amygdala, and really engaging our lateral prefrontal cortex, thinking about system two thinking. And so stigmatizing language, using labels and stereotypes to communicate patient conditions such as they're drug seeking or they're difficult. We can instead describe patients' experiences and actions objectively. Also thinking about the patient's identity, reflect the presentation of self. So like in the case where we use a little girl, it's really an adolescent, and then using pronouns I think is really important as the patient will relate to you. Assuming other identities such as race, ethnicity, language. I had this experience myself in clinic. I had a new patient and I asked about languages because I speak Spanish and just wanted to relay that, but I started with, do you speak Spanish? Because he had a Spanish sounding name and he said, no, I'm Filipino. I was like, oh, okay, I shouldn't have done that. Perhaps starting with, I speak English and Spanish, what languages do you speak, would have been a better move on my part. Mindful language, also thinking about just baseline of assumptions that we make. Stigmatizing language can be come out as patients abusing resources, or like, you know, I already know they're here, so all kinds of assumptions that we can make. And then I give you examples here of ways to think about turning it into more anti-biased language. So substance use disorder, again, thinking about substance use disorder versus words addict or drug seeker, thinking about the toxicology. So dirty and clean also imply and reference good and bad. And so rather than just stating what was in the drug screen. Neuropsychiatric also comes up a lot. This is one I learned just doing some of this, but committed suicide versus died by suicide can be, again, less putting blame, less kind of stigmatizing for a patient. And so, and some other ones you might think about would be like in the case, thinking about the patient bounced back, you know, last hospitalized, medically unsavvy, instead low literacy, low health literacy, wheelchair bound, wheelchair user, etc. So let's look at that case again. And so I came up with over 25 stigmatizing words or phrases. I hope that you came up with at least 10 or 15. And if you got 27 or more, good for you. And so how can we be better? How can we think about this more mindfully? And so I'm going to talk about just a few different ways, but thinking about, again, that individual versus the interpersonal and then the institutional. And so as an individual, we can think about being more aware, being systematic. Checklists can be really helpful. Being more open, again, kind of that looming like open notes and people are going to be reading this, then can also be helpful. And so you can reflect when you're actually documenting. Does this consist of facts or assumptions? What's my state of mind right now? Should I, grab lunch before I finish this note? I also think about those patients who we have the most difficulty with some communications because they might be, again, in that out group or different than us in some way, or some group that have less either affiliation for, or a group that we have less experience with. And so it's also thinking about those times when you're most, uncertain, right? So, a new patient, for instance, in the example I gave, so there's a lot of uncertainty. This is like the first sentence out of my mouth as I'm meeting a new patient, versus somebody who I'm familiar with would be much easier to ask those questions appropriately. Are the facts relevant to the patient's presentation? So often we put things in, like in the case I gave, but don't necessarily need to be there, like they don't further patient care. Thinking about details such as adjectives and the clinical picture, sometimes we like to form a picture, but does that also have like stereotyped views and other ways that we're projecting that, the patient speaking loudly, etc. And then again, how does the patient, how do they identify themselves? And so I like this kind of code of conduct for documentation. So consider, does it cast blame? Does it reinforce a stereotype? Does it include extraneous details? Does it contain pejorative language? And how would my patient feel if they read this? So I rewrite the case. CS is a 17-year-old adolescent with she, her pronouns, with history of childhood trauma, type 1 diabetes with hospitalization for DKA, generalized anxiety disorder, obesity, borderline personality disorder, psychogenic non-epileptic seizures, and slow transit constipation with pain flares. She's brought in by her mother, who uses a wheelchair. The patient's mother has low health literacy, and the patient father died by suicide. She was last hospitalized a week ago. Unfortunately, patient was not able to keep her post-discharge clinic appointment due to transportation scheduling error. Her pain is 10 out of 10 on admission, and pain levels range from 0 to 10. She's presented to other institutions in the Bay Area for pain flares over the past year. When asked, she shares she feels unheard and misunderstood by most providers she encounters. Labs and imaging have been unrevealing thus far for etiologies for the pain. Labs today show a normal CBC, elevated glucose, acidosis consistent with DKA. Her most recent A1C was 9.6, and urine toxicology was negative for all substances tested. Patient and her mother have concerns. Their medical issues will not be adequately addressed during this visit. So thinking about us as individuals, what steps can we take? We can identify conditions that promote stigmatizing language. Am I tired? Am I hungry? We can question and actively revise language that might perpetuate bias, use alternative words, descriptions, and then when appropriate, maybe even share the screen with the patient, show them what you're writing, or even, I haven't done this yet myself, I'll put that out there, but ask patients for feedback. And we know from the open notes studies that have been done that patients, for the most part, less than 15, 16% actually read the notes. And so Dr. Fernandez in her study also shared that patients actually cut physicians a lot of slack about perceived mistakes. And writing your note as if the patient were sitting next to you is another way to think about it. And then enhanced clinician awareness of patient perspective may promote improved medical lexicon, reduce transmission of bias to other clinicians, and then reinforce healing relationships. So what about that interpersonal? I'm proposing that you think about what I'm going to call note writing rounds. So a pair share note, maybe take 10 minutes out of a clinic conference or a time, maybe rounds or something, and find a note of a patient who maybe you've had a difficult encounter with, or you've had trouble with communication. And also think about the inherent hierarchy in our system. So maybe trainees should pair share with each other, not necessarily in some hierarchical way, because this is in no way like punitive. It's more to raise awareness and think about just raising our own consciousness. And so putting that lens of that documentation code of conduct, does it cast blame? Is it reinforce stereotypes? Does it include extraneous details, et cetera? And then I would say, if I'm reading your note, then when I'm giving feedback that I should use I statements. If I were the patient reading this, I might feel hurt, disappointed, blamed, misunderstood. I might be less engaged. And so as giving the feedback, it's not about what you're doing, right? But as the patient, how might you feel if you were reading this? And then lastly, I want to think about, again, institutional. What kind of institutional changes can we make? And I provide you with two. One, thinking about when you type in F/U into the EHR when you're writing a note, it automatically changes it to follow up, right? So that was able to be done. Why can't we also implement other AI kind of flags to think about flagging stigmatizing language? And so thinking about that. And then this came up actually when I was talking to a medical student last week. And I think it's really just intriguing. The VA is doing it, but thinking about patient narratives and written in their own voice. And so thinking about adding that to the medical record. And what he told me is, I asked him about, tell me about a time that you had a difficult encounter with the patient. And he reflected that time when he was at the VA, that there was a patient who was having a difficult encounter with, and when he went back to the medical record and read through her patient narrative, it really changed his outlook and his perspective about her. And so he had a different lens, right, that he was looking at her through, much more empathetic, much more emotional. And again, engaging that prefrontal cortex rather than that amygdala when you're, among a team or flight or fright, etc. So with that, I leave you with our brains. The amygdala is wired to quickly categorize and notice those who are other than us or different than us. With increased attention and practice, we can move beyond our automatic thoughts and reactions to engage in our prefrontal cortex and create new connections. And then we can increase empathy for others through better understanding of patient stories, their lived experience, as well as the history that led to that lived experience. So thank you. And maybe we have 2 minutes for questions.
Thank you very much, Michelle. It was really fantastic to hear this amazing presentation, very eye-opening about the way that patients are depicted, and as you say, from an unconscious place many times. So a couple of questions here. The one is that you may have answered this because I think it was typed exactly when you were talking about the QI issue. It says, are there ways that we can bake into the system QI processes to ensure providers are implementing these practices? So I know you gave the example of the F/U being converted automatically to follow up. Any other quirls there?
Yeah. No, I think this is really, our trainees come up with some of the best interventions, I think. And so, this could be one of your incentive projects, think about, how you can change it in your own system. I offered, the note rounds, maybe implementing that and thinking about, where that fits into your educational time and so forth. And then again, it's not to be punitive, but really to be more enlightening and awakening, because when others see things, that might open our eyes to things that we didn't see ourselves.
And I have maybe just one more, because we're at time here. In addition to decreasing stigmatizing language, should we change our notes to be clearer to patients rather than writing notes for colleagues?
Yeah, no, thank you. That's part of that 3-hour talk about open notes that I didn't get to. But actually, it's found that patients actually appreciate, the not too much medical language, but they don't expect us to change the medicalese that we use because we have open notes. The expectations is really more towards how they're being depicted.
Okay. And one thing, Michelle, I'm going to leave you with, and perhaps we can send this out to everybody. There's a question about if asking for your advice about how to address obesity, i.e. why obesity is considered a judgmental word or term when it's considered a medical condition. And that sounds like a lot to be said. So perhaps you can just write a quick.
I skipped that slide for time, but bring me back and I would love to talk about obesity medicine in its fullest, because that is exactly right. That is an important topic to think about for all our patients. And we do very much stigmatize around obesity.
Excellent. Well, we will look forward to hearing and learning more from you down the line. So thank you again for being here. And thanks, everybody. Have a great day and happy holidays to all of those still on the call. Goodbye.